Hello guys, today our topic is post-infarction heart aneurysm, and please don't forget that this is aneurysm in heart, and it's happened after infarction of myocardium. Okay, let's talk about aneurysm. In most cases develops after extensive transmural myocardial infarction accompanied by necrosis of muscle tissue and its replacement with scar tissue. Etiology: rarely the cause of an aneurysm may be a congenital developmental defect of injury. There are also false aneurysms that occur after previously undergone surgery or bacterial endocarditis. In statistics, aneurysm of the heart develops in 10 15% of patients who have suffered a myocardial infarction, in most cases in the first 6 months and sometimes after a few weeks. Localization: aneurysms are mainly localized in the apex of the left ventricle or on its anterior wall, occur in place of scar tissue that has grown in the area of former myocardial necrosis. In these cases, functionally, the left ventricle seems to consist of a contraction and aneurysmic non-contraction segments. Between them are the gates of the aneurysm. During systole, blood from the contraction segment of the ventricle enters the ascending aorta and partially into the aneurysmal sac, and we call it paradoxical blood flow. What you need to understand: when we talk about paradoxical blood flow, we need to talk about less of ejection fraction, less of minute heart volume circulatory, and it leads to cardiac failure. Blood clots. Of course, in this sac we always can find a parietal thrombosis, and we understand that if thrombi will go away from this sac, we need to talk about embolus, and we can talk about thromboembolic complications. Tamponade of the heart. In the early period of aneurysm formation, when the necrotic area of the myocardium has not yet been replaced by dense connective tissue, rupture of the aneurysm wall and tamponade of the heart with blood poured into the pericardial cavity are possible. Patients are concerned about pain in the heart, chest pains, shortness of breath, and interruptions. A number of patients have a history of myocardial infarction and long-term coronary insufficiency. During examination and palpation, precardial paradoxical pulsation precardial paradoxical pulsation is sometimes determined in the fourth intercostal space to the left of the sternum, separately from the apical thrust. Systolic noise associated with changes in the papillary muscle, prolapse of the leaf of the left atrioventricular valve into the left atrium, and the occurrence of insufficiency of the valve itself. The electrocardiogram reveals the characteristic signs of a heart aneurysm. It is a QS or QR complex, a persistent rise in the complex ST interval, and a negative G wave in the thoracic leads. Radiography. Changing the configuration of the heart shadow sac-like protrusion. Echocardiography. Echocardiography clearly determines the localization of the aneurysm, its size, the presence of thrombotic masses in the aneurysm cavity. This study allows us to determine changes in hemodynamic parameters, ejection fraction, and systolic and diastolic volume of the left ventricle, and other hemodynamic parameters. Selective coronary angiography makes it possible to clarify the localization of stenosis or occlusion of the coronary artery, to assess changes in the vascular bed distal to the occlusion site. Left-sided ventriculography makes it possible to accurately determine the size of the aneurysm localization changes in the myocardium due to the pathological process, to assess the contractility of the remaining part of the left ventricular myocardium as a whole. During the first 2-3 years after the formation of an aneurysm, patients die during the natural course of the disease. The most common causes of the death are repeated myocardial infarction, embolism of various arteries, and heart failure. Indication for surgery and the risk of rupture or covered perforation of the aneurysm, recurrent thromboembolism, and ventricular tachycardia. The operation consists in excision of the aneurysm wall, removal of parietal thrombi, suturing of the resulting defect. During the stenosing process in the coronary arteries, coronary artery bypass grafting is performed simultaneously. And there you see coronary artery bypass grafting. Types, of course. The next one about what we can talk with heart attack involving the papillary muscle with the development of insufficiency of the left atrioventricular valve replacement is indicated. Okay guys, today that's all. Thank you very much for your attention and see you soon. Bye bye.